Good morning and welcome to day two of our annual scientific meeting. My name is Dr. Rebecca Jackson, and I am thrilled to be here today to kick off our session entitled All Things Telehealth, Telemedicine, and Teleresearch. Next slide, please. In response to Dr. Martin Luther King Day yesterday, I thought it was appropriate for us to begin with a quote. "Only in the darkness can you see the stars." This is actually a very fitting quote for the incredible trajectory and transformation of healthcare in the United States and across the world in response to the COVID-19 pandemic. As we talked about in the first session, it is incredibly important that we don't pause, but that we pivot and find ways to meet the same goals and the same responsibilities to continue to move research forward so that we bring the best new ideas and treatments to our patients, and to move clinical care and dissemination and implementation science forward so that we're able to do this in a way that's effective. Today, we're going to highlight some of those pivots and some of those changes that fundamentally have changed the healthcare system. Next slide. Both Nationwide Children's Hospital, The Ohio State University, and in fact, the entire health community throughout our nation and our world needed to figure out within this COVID-19 pandemic, how do we balance progress and safety while meeting the needs of our patients and the scientific community? We began to look at different strategies that allowed us to maintain social distancing in order to reduce the spread of COVID-19 while still meeting those needs. And what we turned to were digital approaches, ways that we can engage with our patients and our research subjects, and new and exciting approaches. Now, you may think this is a brand new response in order to approach both teleresearch and telemedicine, but in fact, that's not true. If you look back all the way to the hieroglyphics or the early scrolls, you can see examples of the very beginning of telemedicine and telehealth. As we move forward over the years, the first big trajectory was in the 1960s, where we actually saw the first adoption of this primarily in the behavioral health arena. But the uptake was relatively slow. In the 1980s and the 1990s, as we began to look at digital strategies and our technology improved, we began to see the next increase. And there was an increase in the amount of teleplatforms available across health systems across this country that eventually affected about 76% of hospitals. But it was really the challenge of COVID-19 that has changed the direction of telecare. Next slide. There are many different faces of telehealth. The encompassing concept is really the use of information and communication technology to deliver care or to engage in research at a distance. And I would suggest that there's really three areas that you should pay attention to in our talks this morning. The first is around telemedicine, which includes preventive, consultative, and curative approaches towards the delivery of healthcare. The second is mHealth or mobile health, the use of mobile monitoring devices and other approaches to get real-time information on your patients or your research subjects in the field. And the last is teleresearch. And we're going to focus on this, particularly in this first presentation, about thinking about ways that we can use digital strategies to enhance subject recruitment and the conduct of virtual trials that are preventive, curative, or in fact, observational studies. Next slide. You can see on this slide the change in the trajectory in response to the early surges of COVID-19. So in the early part of 2019 and 2020, you can see that this curve is relatively flat, and that although there were telehealth engagements, this really was a relatively small way that we engaged our patients and our research subjects. With the onset of COVID-19 in February of 2020, you begin shortly thereafter to see an inflection point in the uptake of telehealth, which has continued to climb almost exponentially on a week by week and month by month basis. And by the summer of 2020, there were more than 10.1 million telehealth visits that were billed to Medicare and Medicaid across this country. So in fact, we had significantly, in an incredibly short period of time, changed the face of the way that we deliver American medicine. But how, in fact, can we begin to understand more about this? Do we understand the patient experience? Do we understand the best ways to utilize this and understand when we shouldn't do this? And so I ask you to think today as we listen to these presentations, how can we begin this effort in telehealth and bring it to the next level? How do we think of ways not only to pivot, but continue to meet the goals that we have in clinical and translational science and in the delivery of healthcare? Next slide. There are really three different approaches for both patient care and research within telehealth. And the first of those are synchronous approaches. So those would be visits that would either be real time by the telephone or live audiovisual interactions, the e-visits that so many of us has conducted. But there's also asynchronous approaches that actually facilitate patient care and research. And so the first of these, for example, would be that ability to store and forward technology like radiology images for reading or digital approaches towards the examination of pathology slides. And so one thinks about this, this really gives us great opportunities in the development of big data approaches using artificial intelligence, machine learning, and deep learning. The second aspect is portals, a way to actually communicate, to share results, education, and approaches that enhances both the patient and the research subject experience. And then lastly are the remote patient monitoring approaches that include clinical measurement reporting, so use of surveys, patient-reported outcomes back to the clinic or back to the research study, as well as the use of patient wearable device, whether that be the use of a Apple Watch, Fitbit, or other type of consumable wearable, to the use of approaches for continuous glucose monitoring, EKG rhythms, or others. Next slide. There are many benefits of adopting telehealth that include improved access to both primary and subspecialty care and access to research studies that could be conducted at any place across the world, particularly for the conduct of studies related to rare diseases. They can also improve health disparities and decrease risk to individuals while improving health equity. For patients and our research subjects, it can promote self-efficacy as well as self-management, as they're able to get immediate real-time feedback regarding their current health status, and can enhance patient and research subject education and engagement, resulting in better outcomes. Remote monitoring allows clinicians and research subject studies to be able to actually follow different parameters within real-time settings. And of course, there can be improved economic and resource utilization. Within the COVID-19, What really spurred on this is actually it also preserved PPE and supported the social distancing recommendations, things that were critical for the first approach for reducing the clinical impact of the COVID-19 pandemic. Next slide. But there are some changes that needed to occur and that in fact have occurred in a very quick fashion that have facilitated this, that will allow us to think about the next steps that we can take regarding telehealth. The first of these were extend our policies related to privacy. So the increased HIPAA flexibility that has allowed new technology platforms has significantly improved our ability to interact with our research subjects and our patients. The second is location, that by allowing rural health centers, federally qualified health centers to serve as eligible sites for the care for telehealth services, as well as allowing for waivers for telehealth wherever a patient is located, has significantly improved our reach and involvement. And then lastly, reimbursement issues, which have extended telehealth not only to the follow-up of established patients, but in fact to new patients. There are, however, limitations that all of us need to think about. There are certain types of care that in fact need to be face-to-face, where there's a direct visit in order to be able to collect information. As our remote monitoring approaches continue to advance, those may in fact reduce in number, but won't entirely go away. The second is the need for us to work closely with stakeholders, both clinician, scientists, and our patients, in order to have the cultural acceptance of virtual visits, as well as access to the technology necessary to engage in this new approach. Next slide. There are tremendous research opportunities. Not only can we leverage this for doing observational studies and randomized clinical trials, but in fact, we can actually study telehealth itself. We can focus on personalization of the telehealth platforms, where we can tailor that interface to address stakeholder needs that actually help us to engage all special populations, such as low literacy, cultural preference, and others. We can expand our ability to understand how to utilize and gather rigorous data on patient-reported and patient-centered outcomes, focusing on outcomes that patients and research subjects truly care about. And we need to do basic science studies on engaging stakeholders in the design implementation to address the barriers to adoption, such as the development of user-centered design that enhances both workflow and adoption, as well as new analytic approaches to utilize all of the data that will now be available to us as investigators and as clinicians. Next slide. As you go through the program today, I want you to consider several questions as you listen to each of these programs. First, how have telehealth approaches changed the landscape forever in both medicine and research? How, as you, as clinicians and investigators, can leverage this information and these opportunities to enhance the jobs that we're doing? The second is, how can we continue to use these technologies to reduce health disparities and improve health inequities? What must we consider to ensure that telehealth actually does not widen health inequities for certain underserved and vulnerable populations? And then lastly, what are the opportunities to leverage our resources across the Ohio State University and Nationwide Children's Hospital, the OSU Wexner Medical Center, and the CTSA Consortium, and nationally to support research and innovation in telehealth? We're really going to be looking for feedback from you in order to understand what are the things that we need to develop to facilitate your ability to engage more closely in this new approach. Last slide. Well, I thank you for listening to this kind of overview of telehealth. And I hope you enjoy our presentations today. Please think of this as a provocative session, ways that you can engage, and we look forward to hearing from all of you. On behalf of Nationwide Children's Hospital, the Ohio State University Wexner Medical Center, the Ohio State University Office of Research, and the Center for Clinical and Translational Science, thank you for attending day 2, and I'm going to hand the program over to Dr. Carolyn Thomas. Carolyn, I just forgot your last name. I can't believe it.
And it's because I go incognito as Jones.
Yeah, who's going to introduce our next speaker? Thank you.
Thank you. Thank you. This is our annual scientific meeting, which usually is face-to-face, and here we are doing it tele. So here we go. So our first speaker is Anthony Keys, who is Program Manager of Clinical Research Projects at Johns Hopkins University Institute for Clinical and Translational Research. He has 15 years clinical research experience, beginning as a study coordinator and a research manager. And after completing his biology degree from the University of Maryland, Tony holds an MBA in healthcare management from Johns Hopkins University. He's also a certified project management professional and has successfully completed several large-scale projects. He founded and directs the Johns Hopkins ClinicalTrials.gov program and co-chairs the National Clinical Trial Registration and Results Reporting Task Force. As part of the COVID pivot at Johns Hopkins University, Tony employed the use of Microsoft Teams to organize interpreters for informed consenting and other COVID pivots. And so with that, I'm turning it over to Tony. Welcome.
Hi, let me unmute here. So thank you so much for inviting me to this. I'm really excited to be here. Thank you, Dr. Johnson and Dr. Jones, for inviting me here, and I really am looking forward to presenting. Can everybody see my screen okay? Caroline, can you just give me a heads up that you can see my screen?
Yes, we can.
Okay, awesome. It went silent there for a second. I just wanted to make sure everything was okay. So as Carolyn explained, I'm the manager of clinical research projects, which in a CTSA group means you basically just do a little bit of everything. And of course, when the COVID pivot happened, we all had to have that balance that was spoken of and really be ready to just do whatever needed to happen. So when the pandemic shut down our research, we had a lot of questions, and we really needed leadership to step up and guide us through this unprecedented time. I promise that's the only time I'll use the word unprecedented. I'm tired of hearing that. So we're very fortunate in the ICTR to have Dr. Daniel Ford as the PI of our CTSA grant. And he assembled the leadership team very early on, focusing primarily on aspects of safety, communication, and operations. Safety, both for the participants and our own personnel, communication to participants and our personnel, and then also to the media and to the world. We really looked upon Hopkins and large academic sites to really provide key communication around COVID, especially as not much was known at its initial inception. And then there was some operational components. You know, what do we do with our non-COVID studies? And what do we do now with all the COVID studies that are actually happening? Most of our infrastructure wasn't prepared for such a pivot. So we really had to switch gears, and this primarily had two phases. For the non-sponsored or investigator-initiated studies, a lot of these investigators needed additional staff to help them with some of the demand, but also some additional skills that they didn't have. So they really reached out to the ICTR at Hopkins for assistance with that. But then we had our sponsored research, in which large pharmaceutical sponsors, either for vaccine research or therapy research, were reaching out to clinicians to ask them to do research studies. Well, those clinicians had never been PIs before and lacked any additional knowledge or infrastructure or any staff to conduct any of this research. So while it would be a great idea for an infectious disease hospitalist or clinician to be the PI, we all know that being a principal investigator is a lot more than just signing a few forms. So we really had to provide that education, infrastructure, and in fact, staffing to help those investigators with those studies. We needed to mobilize volunteers for this research, and we'll get into why we decided to do volunteers. But we were curious about how we were going to make this happen. So we decided to do a survey, and we had to do this survey really quick. And the first thing we had to discuss is who do we distribute the survey to, and then how do we distribute it? Now, we want the survey not to be very lengthy, so we had to focus on essential questions and what type of experiences people had. And we tried to anticipate as much as possible. But of course, perfect is the enemy of the good, and we needed to get it done quick. So we certainly learned some lessons. So we decided to distribute it to the research staff identified on current IRB studies. And this was a two-pronged reason. One, they already had the IRB training because they were members of the IRB study teams. And this primarily is coordinators. We actually have a special designation for lead coordinator, our research nurses and research managers. And we decided to distribute it through Qualtrics. Now, this is not a plug for Qualtrics. You could use SurveyMonkey, you could use RedCap or any other method. We just happened to use Qualtrics. And we shared it as a live link to the members identified in IRB teams. But what we noticed is a lot of the people who got this would end up forwarding it to their colleagues. That was not anticipated, but it ended up being a good thing because we got some additional skill sets that we didn't ask for. But also we had to verify the trainings of everyone too, because we weren't just getting people that were on IRB teams. We assigned a couple study managers, myself and a couple others, to analyze the results as they were coming in, to provide those results to leadership, and then to do matchmaking. We had PIs that needed help, and we had staff that wanted to volunteer, but we had to match those up. Now, some people have asked me, what was your response rate to the survey? That's a very good question. But because of the way we distributed the survey and it was forwarded to so many people, the response rate could not be accurately calculated. Okay. So we have to ask the essential questions. And for us, those essential questions are you willing to work with COVID patients or not? We phrased it that way because we know some people were willing, but not necessarily able because they had contraindications or maybe they had people at high risk within their own family. So we chose to word the question that way. PPE was another question we wanted to ask, as well as how many hours. And we broke this down into 0 to 10, 10 to 20, or 20 and above. And the usual work setting. Hopkins has facilities all over Maryland. So we wanted to make sure if we needed someone to work at a certain facility that we would end up reaching out first to the people that already were familiar with that facility. That became really important when it came to things like weekend badge access. If people were already more familiar with the campus, they're more likely to already have access and know how to get around those facilities. We really were concerned about the supervisors being supportive of redeploying. Some supervisors were not supportive, and we reached out to those individually if we had a good match, but the supervisor wasn't supportive. And then some of the requests were coming that required people that had active licenses, primarily RN license. So we asked that question right up front. So the really important thing that we asked for, and I'm glad we did, was the contact information. Because if you just look for someone in your system's Outlook, you might get a phone number, but most people weren't at their office numbers. So we're really glad that we asked for those mobile numbers because we really needed to contact people quite urgently in some cases where PIs needed people within a matter of days, not weeks. So this is a quick snapshot of one of the questions that we asked. And these are experiences that we know we needed help with: IRB protocols, study startup. Phlebotomy was a big one. We had a lot of requests for that. And then primarily the main one we got was for consenting, both for biospecimen protocols and for therapeutic trials. So anybody interested in the results? So we had over 800 responses, which was much more than we anticipated, much more than we've gotten for really any other survey that we've conducted. And this is the report that came out. This is a quick snapshot of one of the early reports. I want to thank Stephanie Swords for creating this report, who was going to co-present with me, but her COVID duties prevented her from doing such. So we looked at who had a lot, some, or no experience. And we see that phlebotomy, we didn't have a lot of people with phlebotomy, only 100 in this case. But we did have a lot of people that were interested in consenting, a lot of people that had experience with that, as well as preparing IRB protocols. As I mentioned, some of the clinicians that were being asked the PIs had no experience in preparing a protocol. And they needed people to jump in and show them how to submit a protocol, how to write a protocol, how to get it through the IRB. So that was really beneficial. We relied heavily on our staff to help those clinicians prepare IRB protocols. So this is just one of the questions we pulled out. We asked simply, would you be willing to work face-to-face with COVID positive outpatients? We also asked the same for inpatients. And as we can see, about 60% of our staff, 350 so people, were willing to work face-to-face with COVID outpatients. And this report was actually taken within the first few days of April, when not much was known about the spread of COVID-19. So we're really grateful and thankful that our staff was so eager to jump in and help out with this. Now, of course, we're not unique at Hopkins. Many sites around the country have very dedicated staff, and we're just so thankful and so appreciative of them. So, of course, if we needed someone with face-to-face interaction, we would filter our results to only return those that had answered probably yes or definitely yes to this question. Now, a comment about comments. Usually when I do survey research, free text comments are just terrible to work with. You can't do quantitative research on comments, free text comments. And I advised against including this, is there any other information? But I'm glad I was wrong, because some of the most helpful and useful information was contained within the comments. And it was really heartening too to see some of the comments. People use this as a way to share their appreciation for staff doing this. I read comments that were, although I can't help on site, I'm more than happy to help off site. Also, there was a lot of quarantining going on back then too. So people would say, I'm quarantined in such and such a state. I can't come on site, but I'm happy to contribute any way I can off site. And those were very helpful. It was also helpful in other ways, which we'll get to in just a moment. Because we couldn't properly anticipate all the specific requests, some of the PIs came to us and said, I need someone to design a survey in a certain system, or I have the system, but I need someone to analyze the results. Some of the laboratory requests were highly specific to specific softwares, specific techniques. Somebody needed help with PCR. Some people needed help with other things. And those were very highly specific. So what I would do is just filter under the comments of those 800 responses. And lo and behold, I usually got a match to even very highly specific requests. Some of the early requests were for nurses to do NP swabs. Again, we didn't ask that question directly, but when I filtered NP swabs or nasopharyngeal in comments, I got scores of results. So we were able to direct those people with those skills. Now, the regulatory skills, as I mentioned, was highly sought after, including several emergency use authorizations. Some of these requests for EUAs came with hours of notice, and we needed to get this patient dosed within the next couple hours or the next 24 hours. So we really relied heavily on people to jump on these as soon as possible. Then we had issues with non-English interpretation, where we had people that had Spanish speaking or Portuguese speaking or other languages, and they needed interpreters. And this allowed us to matchmake. And I don't know if matchmake is the best word. That's the kind of the code word we used in this, but we wanted to match the request coming in with the people who needed it. So the study team would reach out to the matchmaker, which was myself in this case, and I would work with them to identify their specific needs, query the results of our database to find those needs, and then reach out to those potentials and find out if they would be interested in doing something like this, verify their training. Sometimes I review their resumes, and then I would provide those potential matches to the study team. And a lot of this was very time sensitive. I recall several times on the weekends, I was reaching out to people, and they would pick up on the weekends. Yes, I can help that, or I'll send those documents over and I can start first thing Monday morning. So it was a very interested and involved staff. And this is a copy of the form that I would send over. I'm happy to provide this to anyone who asks for it. But this is the survey kind of at a glance that was kind of searchable. And you could just click on this. I need somebody that has phlebotomy experience, that has done home visits, who can work with outpatients, who's also an RN, who also works at the Bayview campus. And this is probably very close to one of the specific examples we needed. So I would use this form to query the database to find the exact matches. So then the study team would contact, and sometimes they chose multiple people. If they needed 40 hours of coverage and nobody could do all 40 hours, they might have 4 different people doing 10 hours each. And then I would maintain a comprehensive spreadsheet that matched who went to what place, when they went there, who would be their supervisor, what department they came from, what department they went to. And that was a beast, just maintaining that database. Overall, we matched over 15 teams and over 30 staff. And we searched for kind of a win-win, because you can imagine if a staff is in danger of being furloughed because they can't come on site and do their research, and then another team needs people, but there was certain hiring freezes, and just the matter of going through HR and getting them hired would have been prohibitive. We have someone who needs support and another person who needs someone, and to match those up was kind of a win-win scenario. It actually really helped departments too with their finances, because a lot of the teams that needed help we're able to provide some sort of compensation to the department for using that person's time. So really it wins. It's a win for Hopkins. It's a win for the department of the staff member. It's a win for the department who gets the staff member. And also, as I find out, it's a win for the person themselves who just wants to help, who just wants to contribute, who wants to gain new skills as well. So we sought for a win-win-win scenario. And that's the best way to do it. But by far, the most common request we received for help was for remote consent. And we realized this is a university-wide need. There was no specific study team. Well, a lot of specific study teams needed it, but we needed a university-wide approach. And this is because there was a rapid increase for the need of participants or legally authorized representatives for all these new COVID-19 studies. So we needed a way to matchmake people to help. And I like this little diagram I pulled off the web because it's kind of building a house, right? Research is kind of like building a house. You have your foundation, you have your protocol and your timeline and your budget and your contracts, and then you have your other pieces. You have your staffing needs to come in, you have all the logistical support, but that final purple cap right there is the participant. And you can't get that participant until you have that piece right there in red. And that, in this case, is a consenter or a witness to make sure that participant gets consented. Without that piece of the puzzle, you can't put that cap on the house and you can't really build the house. So I think it does a good job of explaining the importance of getting a witness and getting someone to consent per the new IRB policies. And those IRB policies were developed very, very quickly. We have a wonderful IRB director, Megan Singleton, who some of you may know, and she divided this consent policy into minimal risk, which did not require a witness, and greater than minimal risk that did require a third-party witness. So in the old days of research, in the previous era before the pivot, if you wanted to consent someone, you would go face-to-face and consent that person. But now that we weren't allowed to come on site and that there was contact precautions and social distancing, we weren't allowed to be face-to-face. We had to do it remotely. So this required a third-party witness. So every consent that happened for a greater than minimum risk study now required this additional piece of the puzzle, a third-party witness. So this is a very important key and cog in the puzzle. So after the IRB released the policy, we made those slides available. We actually did several recordings. Very thankful to Fred Luthart, who did several of these sessions. We recorded them so people could see them. And we had hundreds of volunteers, over 300 people attended these various trainings. And many of them said, yes, I want to help. I want to be one of these consenters or one of these witnesses. So that was a really great response, very quick from the IRB and from the community at large. We had hundreds of people join this team to help with consenting. So there was two roles. One would be a third-party witness. And this, we decided by policy, had to be an active JHU personnel. It had to be not affiliated with the team. Of course, you can't be a third party if you're affiliated with the team. You had to be present during the entire conversation, not just jumping on at the end. We actually asked that this third-party witness introduce themselves to the participant and say that what their role was. And then their primary role was to verify that the participant physically signed the consent form. This is important because of the safety policy that the originally signed paper that's in the patient's room doesn't leave the room. So it was very, very critical that we had someone that could actually attest to witnessing the form being signed. And then the witness themselves had to hand sign a form, provide a picture of that form so we can get that consent up and rolling, and then mail in or bring in that wet signature so we can maintain that for the study records. And this is what the IRB outlined as the policy, and this is still the policy we follow today. Now, above and beyond that, some study teams needed consenters. And of course, to be a consenter, you have to be an active Johns Hopkins personnel, but you have to now be affiliated with the study team. And this is a heavier lift and a bigger ask. You have to be familiar with the protocol and the consent form. So you have to know what you're talking about before you can consent someone. So this required much, much more time than just being on a call. You had to actually really dive in and become part of the study team. And we did have many people step up and were able to fill this role for the staff, for the PIs that needed it. So now that we had staff that needed or volunteered and agreed to be this, and we had teams that needed them, how were they going to find out about each other? So we know we needed people to volunteer. And this is because none of this was budgeted. I mean, nobody anticipated this in their budgets when they first did them. Plus, we experimented with billing per consent. You know, if you needed 100 consents, but then, you know, if you had to then process 100 payments to certain people, you know, do you bill by the hour? Do you bill by the consent? because some departments build different ways than other departments. It just would have been a nightmare. So we decided early on that people would volunteer. And one of the reasons we were able to do this is we had a pool of 800 people that said, yes, we're willing to volunteer. So we decided to move ahead with that, and no one was compensated for conducting any of these consent forms. And then we wanted a system by which everything could be private. We didn't want somebody, sharing their emails and sharing their phone numbers with everybody. And then also behind the Hopkins firewall for HIPAA reasons and to keep everything private. So this is our solution. And we're not saying this is the best solution. We're not saying this is the only solution, but this is just what worked for us. So we put this brand new email address in here, COVID consent report. We advertised it in a policy. We sent it out through several newsletters, and then it identified a consent pool coordinator, which was myself, to manage these discussions, to educate people, develop SOPs, and help troubleshoot if there was any problems. We created a Microsoft team, and we'll use some of the Microsoft team lingo here if you're not familiar. We use tags to direct communication, and I'll give you an example of what that is in just a second. And it also maintains a history of posts, which are individual requests, and also files, which can be accessed by any member of the team. Now, Microsoft Teams was a good solution for us because it was behind the Hopkins firewall, and it was already preloaded into all Hopkins computers anyway. Now, not everybody had experience with it, but I could say just go into your start and type in Teams, and you'll see it's already pre-installed. And this was important because some of the other options we considered, Hopkins IT would have had to install that on several computers, several hundred computers, and that just was prohibitive. So this is what it looks like. This is actually a screenshot taken yesterday of what the team looks like. We have myself and several others as administrators. We have 17 people that agreed to be consents. We have Portuguese and Spanish-speaking consenters and witnesses, some study team requesters. There's not just 63 teams because there's a couple members of each team that are on there. And then our witnesses, which are there on the bottom. So we can direct communications to specific people by using tag. For instance, if we wanted to request a consenter, we would just type in @consenter and then the message, and that message will only go to consenters. And just a quick note about the roles of these teams. These numbers have fluctuated all up and down. It was a real huge bolus when we first started, but as more on-site research is now happening, people are now leaving the team or asking me to remove them to the team. So these numbers vary wildly. This just happens to be a screenshot of what it was like as of yesterday. So this is a very specific example. I've redacted some of the information here. This example happened back in July. You see it says witness. So this person typed in @witness, and this message only went to witnesses. Is anyone available to consent at 10:30 and 1 o'clock? Very highly study specific request. So someone responds in about a half hour. I'm available both those times. Response back, okay, please send me your email. Another response, here's my email, I'm happy to help. And then that conversation is now taken off of Microsoft Teams, and it's either a private chat within Teams, or maybe a Zoom call or email or some other form of communication. And when these personnel respond using the tags, I can go back in and review any of that history. And that study team that requested this particular witness, whose initials is JL, the next time they need a consent witness, they may do the same thing, just broadcast it out to the entire witness pool, or they can reach out to JL directly. Hey, thank you so much for helping us last time. Would you be able to help us again? So that way it's impossible for me to calculate how many times that the service is used because a lot of the communication is actually taken offline. The files, also really, really important. Some of these files that were created were quite large, and I wanted to maintain version control. So as the policies came out, I would just add them to the files. All team members can see them. And this saved me really, before I realized this was here, I would email all of these files to people, these very, very large emails going through. And some things like the MP4 file from the actual recording were too big to share through email. So I can actually post them on the file and people know where they can go. They can download them and review them at their leisure. And I can maintain the correct version of each of the files, managing it right through Microsoft Teams. So in terms of the tags, in terms of the posts, and in terms of the files, this all made this a solution that was very, very beneficial for us. We did learn a few things. We needed people to be trained in how to do things before they were added to the teams. We didn't just add them to the team. We made sure they reviewed the training first. Also, we learned very quickly that people had it on their PC, but some of these requests were coming late or some of them on the weekends. Once we advised people to put Microsoft Teams on their phone as well, there was a much better response time because people were actually looking at it with their phone. And we didn't realize, but Hopkins notifications presets where that notifications were automatically turned off. You had to actually turn notifications on to be able to see anything. And then we did have some people who were not able to find witnesses because they didn't give much notice. I mean, if you say, I need a witness right now, you are less likely to get something than by the previous example, I need somebody for later this afternoon, especially as it relates to weekends. Okay, so what about non-English participants? Well, we had many multilingual volunteers, and I was able to go into the comments and type in certain languages and then direct communications to those people who said they had these languages. And then the policy we developed here is that interpreter services had to verify that they had indeed been certified through a process. So if you said, I speak this language, you weren't automatically added in as someone who could speak that language. You had to be verified as being certified through interpreter services. Now, there's a small cost associated to this, and we didn't want anybody to bear that burden. So we offer that certification free to any volunteer who wants to become certified. So if certified or upon becoming certified, we then added the volunteer to the team and gave them that tag. And as of now, we have 10 for Spanish, 1 for Portuguese, none for any other at this moment. So if we can't find anybody through this team to volunteer, we can use the Hopkins Interpreted Services, and we've had a lot of success with that. And again, they ask for a lot of advance notice, and we provide that as we're able. So I want to go through a quick scenario. I thought about how to do this, but it just so happened that this weekend we had a consent that had to happen through. And I'm thinking as I'm doing this, you know what, I'm having this presentation on Tuesday. Maybe I should just kind of take some screenshots and tell everybody how this works on a very specific example. So this is Sunday, just a couple of days ago, and this is exactly what happened with some screenshots, of course, redacted. So Sunday at 11 a.m., someone from the study team here, blocked them out, says witness. So of course they're now using a tag. Only the witnesses are seeing this. We have, and I redacted the specific study, a call around 1. So they're giving 2 hours notice. Is anyone available? They sent that at 11:01. At 11:02, someone says, yes, I can be a witness. Here's my email. And then the person says, that's great. I'll send the documents over. And then they typed in @ and then my name. So I get a special notification saying you've been mentioned by name in a witness, in a post. So I can see and I can adjust my notifications to only see things of which I'm specifically by name referred to, or some of the other teams. So this person specifically identified by name, so I got a special notification of this. And then I took over that. The person says, wonderful. So within 5 minutes, Sunday of a holiday weekend, we have someone who's monitoring this and agreeing to participate as a witness. Now, this is an inpatient COVID study with a therapeutic, and very important that we get somebody to witness. So we're very, very thankful to this person for jumping in and doing that. So then I have some work to do too. So I have to send that consent form to the nurse to print, to give to the patient. This patient didn't have a LAR, had the patient. We wanted to do that as soon as possible so the patient had time to review the consent. And then we do have iPads that we give to the participant, or sometimes other devices, sometimes a rolling computer that goes in there. And if in the absence of that, we give the participant a phone. And then the nurse provides a pen. Now you wonder why this is so important. We've actually had consents that were happening where we had the PI and the patient and the witness on the phone, and the participant was ready to sign, but they didn't have a pen. So everybody had to stay on the phone until they could press the call button and get the nurse to come back in with the pen. Sometimes that would be delayed if the nurse had other patients or was otherwise occupied. So we make sure now to say, yes, please make sure they have a pen. You can't sign something without a pen. And then we can set this up in Zoom or in Teams or set up with a phone call. And we want the patient to be there at a minimum. The PI, if required, for this study, the PI was required to be a part of the consent. The consenter, myself, and then the witness. So we want to make sure everybody gets notifications of the Zoom. So this is the email I sent about an hour later. It took me to do these logistics and set up the Zoom meeting. So now we have the Zoom meeting set up around 12 o'clock for the 1 o'clock consent. So the consent call occurred exactly at 1 o'clock using Zoom. The participant had an iPad. Everybody had their screen on, so we could see everybody. The PI told them about the risks and benefits. I told them about the procedures and the compensation and the dosing regimen. The witness identified themselves and said, I'll be witnessing. And then when the participant signed it, he actually turned the form over and said, here's my signature, here's my printed name, here's the date. But of course, our consents require time, and we could see the time was missing. So we said, thank you so much for doing that. Would you mind just putting the time? But the time showed us now we have a fully authorized consent. So the nurse sent a picture of that signed consent, of course, because the original cannot be used. It has to be destroyed. Any paper product that goes into a COVID positive room has to be destroyed. It can't come out of the room. But we need that paper copy because this study requires dosing. And now we're dosing or consenting on a Sunday afternoon for Monday morning dosing. So we needed to provide the pharmacy with photographic evidence that the consent did in fact occur. So the participant sent me those pictures. I had my hand signed copy I was able to include. The PI was actually calling from home and was able to sign the form and scan it back to me. And then the witness, just a few minutes after the consent, sent me through Microsoft Teams, here's a copy of the consent and there's the PDF. So that process worked really well. And then after the fact, I'm still in the process of compiling all the wet signatures. The witness actually lives very close by, so they're going to just drop it off to us. I will get the information from the PI as well as mine and combine all that together so we can maintain that with the study records. And I have a note here. I wish compiling this photographic evidence was as easy as it sounds, but unless you have like an Adobe Reader or a Foxit Phantom or something like that, combining all of these PDFs into one document is a little time consuming, can be a little burdensome, especially if someone takes a picture of their phone with their phone and sends it to you in a text. And you have to then convert that to a PDF, and sometimes the quality isn't so good, so you have to ask for another copy. So it did actually take an hour or so just to put this consent together so that I could send it to the pharmacy so that the patient could be dosed. And the patient was dosed Monday morning because we were able to put this together. And I really relied heavily on my team to help me do this consent and put it all together. So does this work? Well, we know it's been used at least 100 times because yesterday I went through and just kind of looked at all the posts and kind of counted up. But again, that's by far the lowest number because we know some of this communication is happening outside of Teams. Some people agree to be a third-party witness several times. In fact, we know hundreds of consents have happened using witnesses, and the majority of them have accessed this team at some point. We know in reading the comments, it's very heartwarming to see all the comments, both from the study team to the volunteer, just gushing about how appreciative they are, but even the staff saying, thank you for letting me be a part of this. You know, I haven't been on site for a while. I really want to make sure this is happening. I want to be part of the cause. So thank you for letting me help you. And the members continually join and leave at any given time. The numbers could vary wildly. And I don't want to say that this is the only way to do this. I'm just saying that this is the way that we did, and it works for us. So the next steps are, we're looking for new ways to train people. We definitely need to add more non-English speaking volunteers and those of different languages. And then the needs change. You know, sometimes consent could be in that example. Maybe that person has to be consented twice in the same day with 2 different forms, or we need someone to consent pediatrics, or we need someone to consent family members because that person is not able to consent for themselves due to their acuity or language barrier. And then we always want to be improving. So utilizing the lessons learned. And eventually we'd like to analyze this research and potentially report on it. Of course, that's hard to do when you're actually in the trenches living it. But when we do have time to reflect back on this process, we're hoping that we can put something out there and doing meetings like this. And I'm very thankful to OSU and Nationwide Children's for giving me the time to talk about this. I hope that this has somehow been beneficial to you and that you've maybe learned something that you can apply at your institution. And if you have any questions, I put my email there. Feel free to reach out to me and ask me something that maybe I didn't cover or didn't cover well, or any additional questions you have. I did want to include in the references the specific IRB policies in case your institution wanted to reflect on that to see if there's something they can merge into their own. And with that, I'll be happy to take any questions.
Thanks, Tony. I have a quick question. Do you guys use DocuSign?
So I didn't include that specifically. One, because I didn't want to call out any specific software program. We are using DocuSign now. It's in its early stages, but several sites are using it. Several studies are using it and reporting a lot of success with it. It's not prime time yet, so not a lot of people are using it, but we expect that implementation is going to occur very, very rapidly. So yeah, thank you. Yes, we are using DocuSign and it's working well for us.
And are the volunteer employees being required to be put on the roster of people, you know, the delegation of authority logs for each study, or can you avoid that?
Yeah, that's a great question. So if you're in the role of consenter, of course, you have to be added to the study team. But if you're a third-party witness, we specifically don't want you on any of that. We want you to be free and non-biased. You're really just making sure that participant signs the form and just making sure that the participant had an opportunity to ask questions, and that the consenter themselves didn't just say, do you understand, yes or no? They asked open-ended questions. Could you describe to me the risks and benefits? Please let me know. In this particular case on Sunday, I would say, I told him about the dosing regimen. And I'd say, do you remember what I said about the dosing regimen? And they repeated it back to me almost verbatim, showing that they were competent and that they understood the consent form they were actually signing. And the witness did a great job of saying that as well. So yeah, no, not added to the log on purpose because they want them to be non-biased and third party.
Okay. Well, thank you.
You're very, very
And
welcome.
I know you have,
So,
Yes, Dr. Jackson?
yeah. So Tony, as you move forward and you think about this, where do you think are going to be kind of the greatest opportunities for continuing this in the future? So do you see it, for example, in community-based pragmatic trials, or kind of multi-center studies that might focus on rare diseases? Have you thought about ways that this will become part of really our toolkit for thinking about more effective ways for us to reach out to communities and engage populations that potentially had barriers for engaging in clinical research?
Yeah, I love the question. I certainly share your passion for reaching out. The particular software solution we use at Microsoft Teams, we chose because it was keeping all the information private and behind the Hopkins firewall. So it's not something that we can share outside of Hopkins. I'm sure there are other softwares that would allow for a university to university approach. We use, for instance, Microsoft OneDrive for that, which is a secure thing for sharing back and forth. But as far as the communication back and forth, that's kind of locked down to only Hopkins personnel. I'm sure there are other software solutions that could be instituted. I would worry about the privacy of them. I mean, we're very carefully not to share any PHI within these. And you can see I redacted. People would put their phone numbers and their email addresses, but we certainly wouldn't want to put any patient information in there, what room they're in, what their diagnosis is, what their name is. None of that's communicated through Teams. So as long as the privacy could be ensured, then yeah, I'd be on board with something like that.
Yeah. So I think that really offers an opportunity for innovation and creativity to think about ways that you take kind of the initial structures and the approaches that you've developed, and now think about how could we reach that out again, thinking about more community engaged research, where reaching out and again, and doing that within real time in community environments rather than bringing them in for consenting and all of that interaction might really facilitate research. So I think an opportunity for methodologic innovation that will benefit all of us.
Thank you. And thank you for the invitation to speak today. I hope people
all of
got
those.
something about it.
I know you're dashing to another meeting and we want to thank you. Does anyone else have any questions?
Oh, okay. Well, if anybody thinks of any questions later or wants me to re-explain something or is too shy, I hope you recorded my email. I'm happy to help. Since we're a CTSA site, we're all about building infrastructure and collaborating and supporting each other. So please let me know if there's anything I can do to help.
All right. Thanks, Tony.
Thanks, Tony.
You're very welcome. Thank you.
Okay, I think we're going to move on to our next speaker. My name is Bill Smoyer. I'm the Vice President for Clinical and Translational Research at Nationwide Children's, and I have the pleasure of introducing our next speaker, Dr. Ujwal Ramthakar. So Dr. Ramthekar is an associate professor of psychiatry and behavioral health at LSU. And over here at NCH, he serves as the medical director of telehealth and virtual care for our behavioral health service line. So before he arrived at LSU and NCH, Dr. Ramthekar was the co-founding director of a statewide behavioral health access program, and he also served as a consultant for an HRSA-funded expansion grant to implement statewide telepsychiatry in the state of Missouri. So his research in general has focused on methods of healthcare delivery. And in that vein, the title of his presentation is Telehealth Innovations for Pediatric Mental Health Care. So welcome, Dr. Ramthekar.
Well, thank you, Dr. Smyer, and thank you. Can you all hear me okay?
Yes, we can.
Great. Well, thank you for the introduction, Dr. Smyer. You're one of the 5% people who say my name correctly the first time. So kudos to you.
I practice.
And thank you so much for inviting me here today. It's so exciting. Also, really thankful for Dr. Jackson for providing a really great overview of telehealth and telehealth modalities and all the different trajectories that the telehealth has had over time. So today we're going to talk about kind of specific area prior to COVID and how it evolved during COVID in the context of pediatric mental health. Next slide. So the question, again, it comes down to why even innovate? What's the necessity? And here's a major reason when it comes to pediatric behavioral health. Next slide. We are at a critical shortage level when it comes to the supply of trained child and behavioral health psychiatrists. This is a map of the state of Ohio, which shows us the demand and supply of the child psychiatrists per 100,000 children. And here you could see that some counties have severe shortage, but majority of the counties, which is gray in color, have no access to child psychiatry at all. So which means that if they were to receive care for child psychiatry and behavioral health, they really have to travel long distances if they were to really get any early on care. And what it results in is high emergency room visits, unnecessary inpatient hospitalizations. But most importantly, it really changes the trajectory of their development, where they could have been much more successful with appropriate and timely support, and now that's not happening, and that might affect their overall adulthood outcomes, whether it's in education, workplace, or social domains. So to try to tackle this issue of increasing demand and very limited supply, as well as a lot of geographic distances and poor access, we had to innovate, and telehealth was one of the answer that has been emerging in the past decade. Next slide. The problem is a lot of times, whether it's the regulations, whether it's the social determinants, whether it's the budget and finances, or it's the acceptance, we come up with all these different reasons ourselves that limit us in our innovation. And so going back to hundreds of years with Arthur Schopenhauer has said that every man takes his limits of his own field of vision for the limits of the world. And we decided not to do that. And we really wanted to take a bolder, systematic, timeline-based steps. Next slide. So we came up with the BHAGs, our big, hairy, audacious goal of measured innovation approach. Because if we are looking at really the larger community-based impact and technology adoption, we have to take it in a very systematic stepwise fashion. Our thought was, how about we start with the relationship building piece, find the stakeholders, find the communities, partner with the health entities as well as the community leaders and our population. Then how about we then instill the skills and tools, how we teach the skills and tools that are required for effective transfer of knowledge so that we don't need to move people, but just move knowledge using telehealth. Then how do we provide active support in applying those tools in the primary care settings and the regional settings. And then eventually, how do we come up with a plan for collecting data and conduct research so that we could lead to good quality improvement practices and population health level changes. So with that in mind, we started looking at telehealth as the key driver for all of the things that we were trying to achieve. Next slide. However, there have been traditional barriers for telehealth, and there were state regulations, federal regulations. There's issue with reimbursement. So even if you provide the same quality care, the same care, but on telehealth platform, then it is either not covered or is it paid at a lower level. There were licensure requirements. We at Nationwide Children's Hospital draw patients across 4 or 5 neighboring states. And for telehealth practice, you need to have licenses in each of those states, in addition to the state of Ohio, which has been a barrier. There have been technology considerations, although the cost of technology has rapidly come down in the past 5 years or so. Provider readiness, if you are not trained in it, if you have not seen it, if you have not been exposed in it, then you kind of are skeptical about making the adjustment for telehealth, because telehealth is not just adjusting the clinical care on new platform, but really we have to make several clinical adjustments to adapt to this really new setting and venue of delivering care, as well as conducting research. And then lastly, connectivity issues. And we still have majority of our southeastern part of Ohio as very rural, with connectivity issues that have also been a huge barrier for us in telehealth. But nonetheless, we had some a ray of hope, at least from legislation perspective. Next slide. In 2019, Ohio legislature decided to be a little bit more progressive and change a few things around. One was to allow telemedicine visits and be paid for the telemedicine visits, not just for Medicaid, but also for commercial payments. And next was that it opened up the levels of services and the type of providers who can provide these services. And as we know, in any complex pediatric case, it really takes a village. It's not only a physician role, but it also the speech and occupational therapy, genetic counselors, our behavioral health therapy, academic support, nutritional counseling. All of these services are of high value, which are really important for the appropriate clinical outcome for any child. And so the changes in Ohio legislature in 2019 expanded it and allowed a lot more professions to practice telehealth. And we are very proud to have played some role in collaboration with OSU's Center for Telehealth in some advocacy and providing recommendations, which were then adapted for our benefit. So with that, what we did was we started to have plans. The next slide. And we had, next slide, please. So we opened the large behavioral health pavilion. It's $150 million, state-of-the-art, one of the few freestanding child psychiatry and behavioral health installation in the country. We're very proud of it. We have a range of different services. And one of the ways of really accessing majority of the communities that come to us was through telehealth. So we started planning for about 2 to 3 year implementation plan as to how we would develop the telehealth capabilities to connect the local communities with us. However, this guy showed up. Next slide. Sorry, there are animations here. And what this led to was truly challenge us and expedited our timeline from 2 to 3 years to really 2 to 3 weeks. And we were very fortunate that with all of our teams across the hospital, it was made possible. What the next slide shows is the year-to-year volume for, okay, we gotta go log back. few more slides back. Yeah, there we go. Perfect. So this slide shows us the year-to-year volume for behavioral health outpatients. So there was obviously a drop when there was anticipation of COVID-19 related restrictions, but all the services then converted to telehealth only, and there was no in-person or very minimal in-person visits. And what we saw was within a span of 4 to 6 weeks, we were back to our usual in-person volume, except that all of this was being done via telehealth, which really was a testament of not just the feasibility, but also acceptance, both by providers and our families for this modality. Next slide. Um, for some of the actual sub areas of behavioral health and some other pediatric specialties, actually the show rate was much better than our usual in-person show rate. And there was a much better access just because we converted everything to telehealth. And the trend has been stable. So even though things started opening up, even though the hospital did a fantastic job in putting together all the things in order to keep everybody safe with the masking policies, the sanitation policies, the workflows, the prioritization, and all the things, we still saw the very stable trend where we have had maybe 15% of or so in-person visits, and the rest of it is telehealth by choice and by demand. And those 15% are the ones which are more clinically required, where we need a physical exam, where we need to have some intervention that needs some manual manipulation with the child. For example, in children with autism, in children with co-occurring epilepsy and complex diseases, etc. But overall, the trend has remained the same for the past 6 to 7 months or so. Next slide. But it's not just about what we are offering. It's really acceptance and positive experience. We were very skeptical because many times telehealth is very wrongly viewed as a substandard alternative to in-person visit, and which was not true. And our satisfaction surveys from our patients showed that about 90% of the patients strongly agreed that this was a very positive experience, and given a chance, they would continue to do that as well. But it was not without any challenges. Next slide. We noticed very clear ones like network difficulties. A lot of times it was on our end as well, as we were integrating a new system within Epic through MyChart, and we had a very low penetration rate of the MyChart mobile application and devices in the community, and that needed to be ramped up. And whenever there was a network issue, that caused a lot of problems with connectivity. Then privacy issues. A lot of the sensitive content that is discussed and planned during the behavioral health context is really required to have a private space where these confidential conversations could occur. And many times in smaller houses where there's no space, when everybody is in the house because of COVID-19 restrictions, it was a little difficult. And lastly, the digital chasm that kind of led to probably a little bit more disparities for the families who did not have devices, who did not have money to pay for the internet, or who did not have enough money to keep the data on their phone plans, etc. And those were really some of the challenges that we are focusing on from clinical implications perspective. Next slide. But this definitely challenged us to look into different venues and look at how is it possible that we can try to reach more and more kids in the natural settings so that we can provide this care, because now we know that telehealth is easily accepted and very feasible when it comes to delivering the same quality of care. Next slide. And the inspiration actually came from Marcel Proust's quote that the real voyage of discovery consists not in seeking the new lands, but seeking with new eyes. Next slide, please. One more. All right. So better here than Arthur Schopenhauer for sure when it comes to this philosopher. So we then challenged ourselves as to how do we innovate in the models of delivery, because the same face-to-face is really a zero-sum game. All we are doing is shifting, seeing them in clinic versus in their homes. But it's not really building the capacity. It is not really reaching more number of kids, because for each kid that we're seeing, there is a wait list of about 1,200 kids that are waiting to be seen for last few months. So our answer again went back in history. Next slide. And it went down to Will Sutton, the famous bank robber, who was asked, Willie, why do you rob banks? And he said, because that's where the money is. And so we thought, well, where are kids? Well, kids are in the community. They are in schools, they are in their primary care offices, and they are sometimes in emergency rooms. And a lot of times they're homes after schools as well. So that is the framework that we use for developing and disseminating the innovation for care delivery models. The next slide provides a brief overview of 4 settings and the different programs that we were able to implement through innovative telehealth-based models. We'll go one by one for each. Next slide. So for primary care, we thought about integrated primary care. That is a well-known way of embedding behavioral health in the primary care setting, but we needed to do it more efficiently in using telehealth and technology. Then there are consultations, there is collaboration, and obviously education that comes down to a lot of capacity building pieces. Next slide. So the 3 main things that we were able to achieve in 2020 were Project Echo, integration, and something called as virtual office hours. Next slide. Project Echo is one of the national program that started in University of New Mexico that was around building capacity of primary care providers in delivering the specialty care to the patients locally in their community in the primary care settings. Using the same principles, we then developed a child behavioral health project Echo in collaboration with Partners for Kids, our pediatric ACO. Next slide. So we started in 2019 initially with pilot, but in 2020, the need was huge because of COVID, and we were able to expand. It is really a learning collaborative that uses the interactive case-based learning. So it is not a one-way didactic. It is not a webinar. It is truly a collaborative and interactive type of activity where we learn both from spokes as well as the hub. So we use the hub and spoke model where the multidisciplinary specialists are all located centrally at the Children's Hospital, and hub and the spokes are the regional sites and the primary care practices in the community in urban and rural parts of the state. The goal is really to expand their comfort level, to change their prescribing behaviors, to reduce the referrals, and most importantly, initiate the needed treatment right in the primary care setting with the specialist support rather than them waiting for 2 to 3 months until they could see the specialist. Next slide. And this is all could be done in a fun way as well. So this is how the setup looks like. We have a 15 minutes of didactic, which is very pointed, followed by a case presentation by a primary care provider or a regional site spoke member, which we then all discuss. So we don't only just give them the direct recommendations and answers, but we engage all of the audiences in an interactive, facilitated case discussion. So we teach them how to fish rather than serving the fish for them. And we have seen that over the period of 3 months or so, the capacity drastically increases, the comfort level drastically increases. And all of this can be done in a very Brady Bunch fashion as well, during lunch hours every other week, for which they also get the CME credits. Next slide. When we measured some of the outcomes of this, we saw that both for basic as well as advanced cohorts for Project Echo, we had a strong agreement with regard to change in practice or likelihood of change in practice in multiple domains, including diagnosis, screening, treatment, as well as linkages. A lot of times in child behavioral health, we all focus a lot of times just on pills or medications, but there are other interventions that are non-medication based, which then are not available or they're not knowledgeable about it. And we were able to instill all of that knowledge and improve that outcome. Uh, what I have not showed here is we also tracked the initial couple of cohorts with regard to their prescribing practices, and we showed that the prescribing rates of antipsychotic medications went down by about 30% in those cohorts without any additional intervention, just by virtue of participating in a cohort style fashion in Project Echo as well. Next slide. We were able to offer a total of 9 cohorts instead of just 2 cohorts in 2020, which were very well received. And we were able to also collaborate with other specialties within Children's Hospital, whether it be Eating Disorders Clinic or Adolescent Medicine or Thrive Clinic, which is related to gender, diverse youth or substance use, etc. And we were able to offer all of these specialty cohorts to all of our practices. Now, we did not have only reach locally. Next slide. We were able to reach about 41 counties in the state of Ohio within 1 year, and we had about 101 unique practices and organizations ranging from primary care, family care, as well as some of the managed care entities that were able to take a lot of that knowledge and take it to their members. So this was really a great way of disseminating the knowledge, building the capacity so that we are not dependent only on tertiary level and tertiary care, but could really create a system of care that connects the tertiary care with the local communities to reach the kids right where they are and provide them with the same quality of care as they would get at the Children's Hospital. Obviously, this also would provide early access to those complex cases because now we are able to develop our capacity and also provide the support that is needed as well. And the one single driver for this kind of model was telehealth, as this was a telehealth-based intervention. The inadvertent side effect, which was a positive effect for us, was when the transition occurred to everything telehealth in healthcare delivery, the cohorts, the practices that were part of our ECHO had a lot of familiarity about engaging in clinical case discussion on a virtual format, and they felt that their transition to clinical care using telehealth platform went much more smoothly, which was amazing to see as well. Next slide. We then went a step further and we call this behavioral health integration. Now this happens when we embed a behavioral health clinician in the primary care setting or any specialty clinic to provide the services right on spot right there. However, we now took a step forward since this was going to be in community and we wanted to do it in remote areas where we may not have the bandwidth or the resources to have this model to be put in with the same fidelity. We were then able to use the telehealth consultation for case reviews. We also developed an online population health registry in collaboration with the Research Institute here at Nationwide Children's Hospital, which used the REDCap system. And we were able to now collect a lot of the information each time the child was seen in the primary care offices. We then implemented certain workflows so that it would not only just screen during well child visits, but also would catch the signal about what might be looming and then would trigger the primary care office to do other screenings to identify the potential problem. What this did was it identified a lot of kids much early on before they even developed the full-blown symptoms, and we were then able to provide that support right in the primary care setting as well. We all know that from the referral to actually child showing up in the specialty office, the rates are less than 60%. And so about 40% of the kiddos fall through the crack for whatever reasons, sometimes because of just social determinants, sometimes because of geographic distances, sometimes because of poverty and insurance coverage, etc. But this really provided a great avenue to get them the services through our specialty support. Now, the real innovation here was not just the teleconsultation, but population health registry. Next slide. Next slide. What we were able to then do is to really implement measurement-based care to track the progress of a child based on the screening reports that we would collect in our telehealth registry and population health registry. That would then give us a predictive analytics capabilities so that we could predict which child is on the trajectory of ending up in an emergency room with a crisis. And this would then give us a little bit of a glimpse in future to then throw the whole kitchen sink at them with all the wraparound services, care coordination, therapy, med management, etc., all through collaboration with primary care providers as well, which again is a step in building local capacity and developing a nice, seamless, connected, multi-layered system of care with the main driver of technology and telehealth. Next slide. The third is the BH Tips program for primary care that we launched. It is very similar to virtual office hours. We call it Tips because it's a catchy title, and it stands for Behavioral Health, Treatment Insights, and Provider Supports for Primary Care. The goal is really then for the practices who may not have the behavioral health integration resources, but have been through ECHO program or have a general knowledge about behavioral health treatments and medication management, and they just need a quick curbside consult. We do have some phone lines and phone programs here, but for behavioral health, sometimes it's more urgent, it's multiple times, and it really needs a lot more education because in general pediatric residencies, over the span of 3 years, the only education that they get for child behavioral health is less than 3 weeks. And what we know so far is that more than 80% of psychiatric medication prescribing does not come from psychiatry, it comes from primary care. About 40%, and in some cases, 60% of the outpatient volume in general primary care is somehow related to behavioral health. And so while there's not much education provided during regular residency training and CME activities, there is increased demand for our pediatric colleagues to provide all of these behavioral health treatments in their outpatient practices. And this program leverages technology to provide that support and build upon the other two programs that we talked about. Next slide. The way it works is we offer a video-based consultation at a scheduled time from 12 to 2 every single day, Monday to Friday. We have a child psychiatrist and a care manager, a social worker who would be available during that consultation call. Primary care provider who has a question about a case can fill out a very short case form, book that appointment for 15-minute slot, get online, discuss the case. During the case consultation, a specific recommendation, whether it be about diagnosis or about med management treatment plan is provided. In addition, the resources for linkage to the type of services that the child might benefit from is also combined. All of that information is then sent out at the end of the call or by the end of the day if we need to gather more information to the primary care provider through email. All they have to do then is to implement the treatment plan that we developed together right there in the primary care setting. This is truly an on-demand virtual service for busy providers who can, instead of referring them to care to tertiary hospitals or for families to wait for 2 to 3 months, they all can just go ahead and start with the basic treatment plan. Another advantage of this particular program is that for the children who are still waiting to be seen by a specialist, some level of treatment could directly be initiated because the provider is already talking to the specialist. What it does is instead of a specialist seeing 4 children or 2 children in some cases an hour, if they speak to 4 providers in that hour, and each of those provider treats 5 to 10 children that week, all of a sudden we have impacted 100 kids within the span of 1 hour, which really adds to the multiplier effect of our very restricted resources, but high demand in the community. Again, the main driver here is technology and leveraging telehealth as well as the um, uh, innovation in this service and care delivery that leads to this increased capacity. Next slide. Same happens with school as well. We are developing similar systems and have implemented similar things across about 80 schools in Columbus area and in the outskirts. Next slide. This infographic kind of shows the tiered model where we have a prevention approach for everybody, then a targeted student population depending on what we find, and a very tiered, top tiered approach for the kids who basically now need direct care. We collaborate with schools, provide multiple levels of care through our pediatrics department and in collaboration with behavioral health to really implement what we have been doing in the primary care setting as well. Next slide. Third piece is remote hospitals. Next slide. So by this, what I mean is a lot of times when somebody is in crisis and very few hospitals have the behavioral health services, what happens is kids go to the local emergency room, they clear them medically, determine it's a significant safety concern and a behavioral health issue, but they don't have capacity to assess it. They put them in the ambulance, they come to the Children's Hospital emergency room, but wait, after getting cleared again in the main emergency room, they have to come to the behavioral health, psychiatric crisis department to get evaluated. And about 80% of the time they get discharged because they don't really meet the inpatient level of criteria. All of this takes more than 12 hours, about $4,000 to $5,000 in bills, significant inefficiency, but most importantly, huge dissatisfaction for the families and the kids in the crisis. What if we were able to develop an interconnected system where we can offer our expertise from emergency rooms and crisis to all of our regional partners and local emergency rooms? Now, that is exactly the plan that we are working on, starting with our own internal Lewis Center emergency room, and then eventually take it to other regional partners so that nobody has to travel and they can get the crisis evaluation in their local site itself. Next slide. Same thing that could happen with the video-based or telehealth-based connectivity for crisis medication in other settings as well, including first responders, because when the crisis call goes, it goes to 911. Imagine having a support of a behavioral health crisis clinician to our first responders and authorities as they go and assess these children for safety. A lot of these unfortunate scenarios where the kids then have to be handcuffed or put in the police car, brought to the hospital, walked around in jumpsuits, all of those could be avoided if you could do that. And that is exactly what the next step we are working on. So what's next? Next slide. This is just the innovation in how we adapted to change the delivery system for higher impact so that we could really try to meet some of the demand that is ever increasing with the mental health crisis in addition to the COVID-19 pandemic. What we have realized is the traditional face-to-face care adaptation is not going to be sustainable. We really have to continue with this healthcare delivery innovation for a population health level change and bring up healthcare delivery research as well. These models are very easily replicable in other specialties and not just restricted to behavioral health as well. What we really need is a systematic way of doing things. Next slide. So what we have been doing is really creating the virtual care center of excellence. Although we don't have that at this point of time, the way we are approaching, at least in behavioral health, is to use these interdependent levers of clinical service, education, and research, where we can really continue to develop these innovative care models, but also take on the next frontier of digital health and digital health tools in delivery of care, as well as conducting research and developing new modalities of care. We have been very fortunate for partnership of CCTS at OSU as well for some of our very small pilot programs where we're looking at feasibility of things like real-time transcription to reduce the burden of documentation. Or we're looking at the voice assistance and artificial intelligence in dissemination of some of the information, or for improving the overall adherence to the treatment, as well as identifying the risk factors for a certain select group as well. We are also working on virtual reality-based interventions for certain conditions. And all of those things would come through research levers that are embedded in clinical services and could be disseminated through education. Next slide. We really help to leverage the main four pillars. If we could keep clicking, the technology and connectivity is the first one, followed by the provider training in that technology and newer models of care, leading to next part of improving quality as well as sustainability of all the innovation at a large scale. And lastly, and more importantly, do it in a way that is equitable, fair, and is accessible to all of the population. Next slide. Um, all of this is going to be possible through a lot of collaboration, not just among different specialties of the hospital systems, but also the research institutions. And as I said, the great example already has been our support that we have received through our own research institute, as well as partnership with CCTS and OSU as well. Next slide. And with that, I'll stop. This has been such an exciting journey, and we are hoping that a lot of this could be translated into other areas. And we look forward to much more exciting, innovative, and digitally rich telehealth-based 2021. Thank you. You're mute, Dr. Smyer. There you go.
Sorry about that. So thank you very much for such a forward-looking presentation. It's refreshing to see that something so positive could be facilitated by the pandemic, but congratulations on all that you have done, and I applaud your ambition for the things you're planning to do. So we have, I think, a few minutes before our break for questions, if anyone has any, but maybe I can start out with one or two for you. So one of the key drivers, whether we like it or not, of this was the decision that this would all be reimbursable. Do you think that you could speak about how stable you think that is and what the implications are for all of your vision and the potential translatability of this to other centers and other disciplines in the context of reimbursement rates and where you think that's going?
Great. I think it's a great question. Reimbursement comes down to the bottom line of how we operate and how we have to pay salaries and get resources together. Fortunately, there has been a drastic shift since 2019 at the federal level for developing new CPT codes and then attaching the dollar amounts for these newer models of care. So one example is provider-to-provider consultation. We now have CPT codes, and it's up to the states to adapt and attach dollar amount for that. Other thing is e-consults that could be done internally through Epic as well. It's a great way to track how many times we could really efficiently provide specialty consultation, but it's time of the specialist that's going in. Or our PCTC line, for example, where anybody could call in to talk to a specialist. It's time. What we are hoping for is, as we are moving towards more and more value-based care, and we have our own accountable care organization as well, that there is a lot of value in supporting and funding these initiatives for much larger cost savings. And the good example are larger systems like Partners in Boston, the Harvard system, Kaiser, and Intermountain. What they have all done is they really have budgeted the potential cost savings with really a return on investment up to 6 times if they deliver care and develop these kind of innovative care models as well. Until we are big enough to take that value-based care risk, a lot of times this could be really translated from other metrics like provider burnout, provider efficiency, reduction in show rate that increases revenue, a reduction in hospitalizations, which then many times leads to a lot of uncovered hospital days, which is where we lose a lot of money. So a lot of times we could see it as revenue generation by cost savings. And that is kind of the model that we're working through at this time. And we're fortunate to have a lot of support for innovation and research at the Children's Hospital, and a lot of technical support and talent when it comes to technology from OSU. But so far, the things are turning towards more and more reimbursement for sure.
I don't see any other chat questions that have come in, but I just want to highlight that in the spirit of the CCTS, one of the very appealing things about what you're putting forward, particularly with where you're going, is the translatability to other disciplines and potentially to other hubs in the CTSA system. So do you have a sense for whether there are others doing anything similar or analogous around the country to what you're doing? And it sounds like you did something similar in Missouri.
Yes, we did something similar in Missouri. Again, it was mostly funded by private foundation initially, and then HRSA-related grants came together. Things are happening in patches in certain areas, but the vision that I had said in second last slide, that really developing the centers for telehealth and center for excellence for telehealth-based or technology-based innovation. In fact, proposing to not just call it telehealth, but calling it virtual care, so that it involves all the aspects, including research into digital health innovation, is probably the way to go. Some places have developed it. A good example is Thomas Jefferson University, where they've created Jeff Connect, or Mercy in Missouri and 6th area, where they have created Mercy Virtual, or Kaiser's Center for Telehealth, or even our neighbors in Cincinnati, they have created Center for Telehealth. And we don't even have to go farther. At OSU, we have Center for Telehealth with Dr. Levine's leadership, where it provides a central structure to then be a clearinghouse for rapid scalability, so that people don't have to go through their self-discovery and figuring it out, but they could come to this center, which could then facilitate in springboarding them and could act as an innovation hub. So there are some examples across the country, and I think it's a real opportunity for us to develop something like that here, since we have all the pieces of the puzzle. It just has to be put together in one place and given a name for more efficiency.
All right. Well, thank you very much again for such a nice presentation. I don't see any other questions. And Tiffany, I think we have time now for a break.
We do.
Scheduled
I
till
think.
45. When did you want people to come back?
Sorry, one moment.
I think we're at
10. Yeah. Oh, so we were supposed to start the next session at 10:45. So that is when our speakers are supposed to be there starting. So if everyone can have a brief break and try to join us by 10:45, that would be excellent.
Great. Thank you for having me again. Thanks a lot.
Thank you.
Thank you very much. All right. We'll see y'all back in 5 minutes.